السلام عليكم. نبدأ شرح Obstructive jaundice, cholecystitis and cholangitis. Starting with the definitions. Cholelithiasis means gallstones. Cholestasis means blockage of bile flow. Biliary colic is intermittent right upper quadrant pain caused by gallstones. Acute calculus cholecystitis means inflammation of the gallbladder caused by gallstones. Chronic calculus cholecystitis means there is obstruction of the cystic duct by gallstones that is leading to scarring and non-functional gallbladder. Chronic acalculous cholecystitis, inflammation without gallstones, and there is abnormal gallbladder ejection fraction. Acute cholangitis is inflammation of the biliary duct by bacterial infection. This is what the biliary duct is. It is part of the digestive system. There is intrahepatic duct, extrahepatic duct, gallbladder, and common bile duct. If there is inflammation in these, not specifically common bile duct or the gallbladder, this is called cholangitis. Also, we have cholelithiasis. This is stones of the common bile duct. Mersey syndrome we're going to explain further later, and obstructive jaundice will also be explained. Now, for the biliary diseases, starting from low severity to high severity, the lowest severity is cholelithiasis, just stones, no inflammation. Cholecystitis is next with inflammation. Cholelithiasis, this is stones of the common bile duct, and the most severe is cholangitis. This is just some information about cholecystectomy, which is the most common surgical procedure undertaken in the world, with a female to male ratio of 2:1, most common elective surgery, and the prevalence of gallstones is 10 to 15% in adults. Now we move on to the gallbladder physiology. The gallbladder concentrates and stores bile, which is made by the liver. It contains cholesterol, bile salts, and phospholipids. If there is disruption in the ratio of these components, this can form gallstones. Bile flows from the liver into the gallbladder, and when there is food in the intestines, cholecystokinin stimulates the contraction of the gallbladder, so bile moves from the gallbladder into the cystic duct, into the common bile duct, into the intestines through the ampulla of Vater. For the composition of bile, 95% of it is water, and some things are dissolved in it, such as bile salts, bilirubin, phospholipids, and cholesterol. Bile salts, there are two types, primary and secondary. Primary, these are made by the liver, and secondary, they are converted by bacteria. Primary, such as cholic, deoxycholic acids, and secondary, such as deoxycholic and lithocholic acids. Bilirubin phospholipids is lecithin. The phospholipids, you can see here, they help, this is lecithin, they help in dissolving the cholesterol inside for the transportation of lipids, because cholesterol is insoluble in water. Again, any disruption of these components could lead to gallstones. Other components of bile are amino acids, steroids, enzymes, porphyrins such as heme, vitamins and heavy metals, exogenous drugs, xenobiotics, and environmental toxins. Now we start with the first pathology of the gallbladder, starting with gallstones. These are very common. So what are the risk factors? They are higher among females, with a female to male ratio of 4:1. Why? Because endogenous sex hormones enhance cholesterol secretion and bile cholesterol saturation. Again, this disrupts the proportion or the percentage of bile components. Also, another factor is progesterone, which relaxes the muscle and then impairs gallbladder emptying, so the bile stays in the gallbladder for long periods of time, making it thicker. Also age, as age increases, the bile itself is more saturated with cholesterol, lithogenic bile. Other risk factors we know about the mnemonic 426Fs: female, fat, 40, fair, fertile, and family history. Other factors are rapid weight loss, dietary factors such as fatty diet, high intake of cholesterol, medical conditions, diabetes, hemolytic state. We know about sickle cell disease, also cirrhosis, IBD, hyperlipidemia. Other factors: oral contraceptives, prolonged fasting, parenteral nutrition, because there is no cholecystokinin to stimulate the emptying of gallbladder, bile duct stenosis caused by stricture, sclerosing cholangitis, or congenital cyst. Sclerosing cholangitis is an autoimmune condition where there is inflammation of the bile ducts or the biliary tree. Also some surgeries such as vagotomy and ileal resection. So what is the pathophysiology of gallstones? First is cholesterol supersaturation in bile, the disruption of the composition of bile. This could be by many factors such as rapid weight loss, high intake of cholesterol, or female sex hormones, as we mentioned before. So if the ratio is disrupted, cholesterol crystals may form. Second, we have crystal nucleation. This is caused by myosin hypersecretion. This is a glycoprotein released secreted by the gallbladder mucosa. This forms a gel-like substance, so it traps cholesterol crystals, and this leads to nucleation. This makes bile more viscous and gel-like. Gallbladder dysmotility, again the bile stays in the gallbladder for long periods of times, and then cholesterol precipitates, causing it to form crystals. Also gallbladder absorption, which is when the gallbladder concentrates bile, and this makes it again more susceptible for gallstones. Bile stasis, which is slow or reduced emptying. We talked about the risk factors. Here we have diabetes, pregnancy, oral contraceptives, prolonged fasting, or total parental nutrition. This is a diagram of the transport of cholesterol. These are the bile salts, and this is the lecithin, which we talked about, which is a phospholipid. This is what helps to transport cholesterol. Now, we need to know also the types of gallstones. The most common is cholesterol gallstones. About 70% of the components of the stone itself is cholesterol. The pigmented have less cholesterol, of less than 30%, and there is a mixed type which has 30 to 70% of cholesterol. So the pigmented, there is two types, black and brown. Black is when there is excess bilirubin enters the bile, such as in hemolytic conditions or cirrhosis, and we have a chemical, calcium bilirubinate, that makes this dark. Also, for brown pigment stones, we have calcium bilirubinate, the same as this one, and calcium soaps. This is what's different from the black pigment stones. This is caused by bacterial infection and dysmotility. The bacteria releases beta-glucuronidase and phospholipase. This just disrupts the bile components. The beta-glucuronidase hydrolyzes conjugated bilirubin and makes it unconjugated, undoing what the liver did. So the unconjugated will settle because it is insoluble in water. The phospholipase will break these phospholipids and then will make also the cholesterol. There will be no vesicle surrounding it, and it will also be insoluble. For the clinical presentation, most patients are asymptomatic, about 80%. And when they have symptoms, they have biliary colic, which is the pain that we talked about. It is severe and constant. It is provoked by meals and may be worse at nighttime. Fatty food intake stimulates the contraction and then increases the pain. As for the location and radiation, it is a right upper quadrant pain, and it can radiate to the right scapula, which is called Bow's sign, or the posterior shoulder area. For physical examination, there will be a negative Murphy sign. Why it is negative? Because this is just gallstones and not cholecystitis, so the gallbladder is not inflamed. Other symptoms include nausea, vomiting, fatty food intolerance, bloating, fatigue, weight loss, jaundice, pruritus, which can be worse at night. The natural history, as we said, most are silent, and symptoms may develop over 15 to 20 years. Almost all become symptomatic before complications, and the type of pain is called biliary colic. But intolerance to fatty food or indigestion is too low to be clinically helpful. So if there is a only presentation of intolerance to fatty food or indigestion, that does not mean it is immediately gallstones. There could be a million things causing this. So here we have the differential diagnosis of these symptoms. Diseases of the gallbladder could be cholecystitis, which is the inflammation, or choledocholitis, which is the stones of the common bile duct, or cholangitis, which is inflammation of the biliary tree. Or it could be duodenal ulcer, or hepatitis, or appendicitis with atypical presentation, because typically appendicitis is a right lower quadrant pain, or pancreatitis. For the complications of gallstones, maybe a patient will come and say that, why should I remove these gallstones if they're not causing any harm? There could be complications. So the most common is acute cholecystitis, which is the inflammation of the gallbladder, which occurs about 10 to 20% of symptomatic patients with gallstones. Also, gallbladder gangrene, perforation, empyema, which is pus, and these are severe complications. Also, emphysematous cholecystitis, which is when there is gas-forming bacteria causing air trapment, such as Clostridium or E. coli. Also, carcinoma or cholecystectomy enteric fistula, when there is connection of the intestines with the gallbladder. Also, diseases of the common bile duct. There could be choledocholitis, when there is obstruction of the common bile duct. And this happens in about 8 to 15% of symptomatic patients, with also cholangitis, gallstone, pancreatitis. All of these can happen. In the gut, gallstone ileus, we will talk about later, causes obstruction, and management can involve ileotomy with stone extraction. Lastly, Mersey syndrome, which is a compression of the common bile duct by a stone impacted in the gallbladder, Hartmann's pouch. This we'll talk about later. All of these in green, we will talk about later. As for the investigations, first of all, of course, lab work, amylase and lipase to rule out pancreatitis, liver function tests, complete blood count, coagulation profile, and if there is acute cholecystitis, the markers of inflammation or inflammatory markers will be increased, WBCs will be increased, alkaline phosphatase and total bilirubin will be increased. But this is not sufficient. The gold standard of diagnosis is imaging, and specifically ultrasound. But before ultrasound, other modalities of imaging is X-ray, but it is not sufficient because gallstones are not radio opaque. KUB means kidney, ureter, and bladder X-ray. We can do it only if there is suspicion of obstruction, such as the gallstone ileus, where we can see the air fluid levels, but otherwise it is not sufficient. The most sufficient is the ultrasound of the abdomen. It has a low false negative rate, and it is accurate for bile duct dilation, gold standard again for diagnosis and complication. What we look for in the ultrasound is thickened gallbladder wall of more than 3 millimeters, pericholecystic fluid or distended gallbladder, or Murphy's sign with the ultrasound probe. Of course, before the lab and imaging, we do physical examination and history. But here we can also find a positive or Murphy's sign positive will be in inflammation. We can see here some of the radiographic images of ultrasound. We can see here there is stones with acoustic shadowing. This is the darker area underneath the stone because the stones have calcium that block the ultrasound waves. Also here you can see a polyp, and we can recognize and differentiate polyps from gallstones because it cannot be moved by the ultrasound probe if we try to mobilize it. Also here more pictures. This is the normal gallbladder. It is not distended. It is not doesn't have a thickened gallbladder wall, and there is no stones inside. The wall thickness is less than 0.3 centimeters normally. Here we see the gallbladder is normal. However, there is a stone here with acoustic shadowing. This is a sign of cholelithiasis. Some of the findings in ultrasound may not be related to cholelithiasis. It could be for cholecystitis, which we will talk about later, some of which are distended gallbladder or thickened gallbladder wall. Also for cholangitis, there could be a dilation of the biliary tree and the common bile duct. Here you can see the free fluid that can surround the gallbladder, and also the gallbladder wall thickness is significantly increased. The third mechanism for finding gallstones is HIDA scan, which is a nuclear medicine scan that uses radionuclide IV extracted from blood excreted into bile. If there is uptake by the liver, gallbladder, and common bile duct and duodenum within 1 hour, this is normal. Here you can see a picture of the HIDA scan. If there is slow uptake, just slow uptake means hepatic parenchymal disease, any disease within the liver itself. If there is filling of the gallbladder or common bile duct with delayed or absent filling of the intestines, means obstruction of the ampulla. Here you see, this is the common bile duct, this is the gallbladder, this is duodenum. If these two fill and the intestines are not, means that bile is flowing but it is not entering the intestines, meaning there is obstruction of the ampulla, the transition between the common bile duct and the intestine. If there is no visualization of the gallbladder, means the gallbladder is not filling and the common bile duct and the duodenum both are filling, but there is no filling in the gallbladder. This means that there is obstruction in the cystic duct, or that the gallbladder is inflamed, acute cholecystitis. This is very sensitive and very specific. Also, HIDA scan is very good for in cases of signs of symptoms of cholecystitis without stones, which is called acalculous cholecystitis. You do an ultrasound, there is no stones, but there is signs of inflammation. This we can diagnose with a HIDA scan. Other radiological modalities is CT scan for complications, MRCP, which is magnetic resonance cholangiopancreatography. This can detect gallstones and common duct stones. This is an image of MRCP, and no contrast is used for MRCP. The next investigation we can do is ERCP, which stands for endoscopic retrograde cholangiopancreatography, and this is an invasive way of finding gallstones, and it is both diagnostic and curative. The way it is performed is through an endoscope that goes into the stomach and through the duodenum, where we can enter the ampulla of Vater with a catheter and we can extract the stones there or do other surgeries such as sphincterotomy. We can also use balloon catheters to extract the stones, and unfortunately there is a risk of acute cholangitis after the endoscopic papillotomy unless the duct is cleared of the stone or a nasobiliary catheter is left in situ. This is the nasobiliary drainage tube, which can be left to reduce the risk of acute cholangitis. Also, ERCP can be used for imaging, not only for intervention. We can use the endoscope and then we can inject IV contrast into the biliary tract through the endoscope and X-ray is taken. Lastly is endoscopic ultrasound. This can be used for suspicion of malignancy. Again, this is an endoscope that goes with an ultrasound probe. Lastly, the management for biliary colic, which is the pain caused by cholelithiasis, is analgesia, elective cholecystectomy, and avoiding fatty food. Now we move on to the second gallbladder disease, which is acute calculous cholecystitis. It is inflammation of the gallbladder in the setting of obstructed cyst or bile duct caused by gallstones. Most patients have complete remission within 1 to 4 days. About 25 to 30% of patients require surgery or develop some complications. 10 to 15% of cases have perforation. In this picture you see here, there is a collection of pus. It is distended and there is pus filled. This is one of the complications of cholecystitis. The diagnostic criteria for acute cholecystitis is when there is local symptoms and signs, systemic signs and imaging findings, one of each. And the guidelines for grading of severity, grade 1 is mild inflammation with no organ dysfunction. Grade 3 is severe there is dysfunction of any organ or system, and grade 2 is moderate. For the management of acute cholecystitis, for all patients we have NPO, so they have nothing by mouth, IV fluids, IV broad spectrum antibiotics. For temporary non-operative management, dissolution therapy, we try to break down the gallstones by ursodeoxycholic acid and quinodeoxycholic acid. For the operative management is cholecystectomy within the golden period of the first 72 hours, or if the non-operative approach fails. For unstable patients, we do percutaneous transhepatic cholecystotomy. So this is a tube that is inserted through the liver and into the gallbladder with a tube to drain the gallbladder of the bile and reduce the inflammation. Talking about the cholecystectomy more, it is laparoscopic usually, cholecystectomy. Timing could be early or interval operation waiting for a period of time, or it can even be elective. For patient consent, it can be converted into an open procedure. There is a risk of bleeding, bile duct injury, damage to other organs, Merisi syndrome, and biliary strictures we will talk about later. During the surgery, there can be some findings, which there is a grading scale for the findings. For the indications of prophylactic cholecystectomy, there is no inflammation, but to prevent it, not usually recommended, but sometimes for bariatric surgery, or if the gallstones are larger than 2.5 centimeters, pediatric gallstones, congenital hemolytic anemia with gallstones, porcelain gallbladder, incidental gallstones found during intra-abdominal surgery and prior to transplantation. There is guidelines for the treatment. So cholecystectomy can be done within the first 72 hours. ERCP with stone extraction can be done during, before, or after cholecystectomy. If the patient is having cholelithiasis that are symptomatic, we can do laparoscopic cholecystectomy. Moving on to acute acalculous cholecystitis, we talked about before. This is when the gallbladder is inflamed in the absence of an obstructed cystic or common bile duct. There is no obstruction, just inflammation. Typically occurs in critically ill patients. For example, severe burns, multiple trauma, lengthy post-operative care, or prolonged intensive care. About 5% of cholecystectomies are caused by acalculous cholecystitis. The cause is thought to have an ischemic basis and may cause gangrene. There is an increased rate of complication and mortality. A subtype of acute acalculous cholecystitis is acute emphysematous cholecystitis, which is uncommon subtype caused by infection with clostridial organisms, causing occlusion of the cystic artery. So again, this is an ischemic basis, associated with atherosclerotic vascular disease and diabetes. Moving on to empyema and mucocele. Empyema refers to gallbladder filled with pus due to acute cholecystitis. We saw in this picture here gallbladder filled with pus. And mucocele refers to an over-distended gallbladder with mucoid or clear and watery content. The signs and symptoms: right upper quadrant pain, continuous and longer duration. For signs, fever, local peritonism. Murphy's sign will be positive. Investigations: we will do blood tests, urea and electrolytes, full blood count, liver function test, amylase, and C-reactive protein. We also do ultrasound of the abdomen. We will find thickened gallbladder wall, distended gallbladder, pericholecystic fluid, and stones. For treatment, intensive monitoring, nil by mouth, analgesia, intravenous antibiotics, percutaneous cholecystectomy tube, and cholecystectomy. So similar to the management of acute cholecystitis. Moving on to gallstone ileus. This is a long-standing gallbladder stone which results in inflammation surrounding the bile. This is when the stone goes from the gallbladder to the intestine, and then it moves through the intestine to the narrowest part, which is the ileum. So it causes obstruction of the small bowel, and the symptoms are small bowel obstruction for vomiting, abdominal pain, distension, and for the signs: abdominal distension, obstructive bowel sounds. As for the investigations, similar to what we said before, but we do hepatitis screen and coagulation screen. And also, this is important for cases of obstruction, is plain film of the abdomen. We can see air fluid levels and also air in the common bile duct. For treatment is laparotomy and removal of the stone from the small bowel. Laparotomy is when we open the abdomen longitudinal and we perform the surgery. Next, we have Mersey syndrome, which we've mentioned before. It is an obstruction of the common hepatic duct. It is an extrinsic compression because of an impacted stone in the cystic duct or Hartmann's pouch, causing obstructive jaundice or fistula, a connection. Here you see a picture of Hartmann's pouch and the cystic duct. If there is a stone in this area, it can compress the common hepatic duct, and then bile will not flow into the intestine, causing obstructive jaundice. It occurs in 0.7 to 1.4% of all cholecystectomies. It can be not recognized and causes a significant morbidity and biliary injury, specifically for laparoscopic surgeries. For classification, Type 1, there is no fistula present, only compression. Here a picture of type 1, no fistula, only the compression of the common hepatic duct. The other types, type 2 to 4, there is fistula present. Here you see in type 2 there is a fistula involving a third of the common bile duct. In type 3 there is less than 2/3 of the common bile duct obstruction, and type 4 when there is complete obstruction. Type 5 that when there is connection between the gallbladder and the intestine. Next is cholecystitis, when there is a stone impacted in the common bile duct, and this causes obstructive jaundice. The symptoms are pain, jaundice, dark urine, and pale stool. The signs are jaundice. Investigations include blood work, as we said before, hepatitis screen, coagulation screen, and ultrasound of the abdomen to visualize the stone. For the treatment, we do ERCP. This time it is curative. For the definition of jaundice, it is defined as yellowish discoloration of the skin, sclera, and mucous membranes from accumulation of the pigmented bilirubin. The normal bilirubin, total bilirubin, is 0.3 to 1.3 milligrams per deciliter. It is considered jaundice clinically at the level of more than 3 milligrams per deciliter. Now let's go over a review of what happens to bilirubin in the body. So first, RBCs are broken down by macrophages, and the result is unconjugated bilirubin bound to albumin in the blood. This is because unconjugated bilirubin is not soluble in water, so it has to be bound by albumin. And then it goes into the liver. The liver conjugates bilirubin, and then it becomes soluble in water. After that, it goes through the biliary system. It is excreted to the small intestines in the duodenum, and it continues its journey to the colon, where it is converted into urobilinogen by bacterial proteases. And what's left, sometimes it gets reabsorbed through the portal vein, and it goes in the liver, in the blood again. It goes to the kidneys, and then it is filtered, and it contributes to the color of urine. Most of the urobilinogen is converted into stercobilin, which gives feces its color. This is important to understand because any block or accumulation of bilirubin, whether conjugated or unconjugated, will result in some signs and lab findings. We can classify jaundice or hyperbilirubinemia into prehepatic, hepatic, and posthepatic. Prehepatic when there is overproduction of bilirubin as a result of hemolysis. This creates an increase in unconjugated bilirubin, the type that is insoluble in water, and this can be caused by sickle cell anemia, thalassemia, or hemolytic anemia. You can see in hemolytic jaundice or prehepatic jaundice, the unconjugated bilirubin is excessive and the liver cannot keep up, so there is an increase in unconjugated bilirubin, as well as there is an increase in conjugated bilirubin that is excreted. So this will result in increased color of urine and stool. For hepatic jaundice, there is an impaired uptake or conjugation or even excretion of bilirubin. This could be caused by hepatocyte damage or enzyme defect. Maybe it is caused by hepatitis or cirrhosis, any disease of the hepatic parenchyma itself. And this could cause accumulation of either conjugated, unconjugated, or even both types of bilirubin. For post-hepatic, there is regurgitation of unconjugated or conjugated bilirubin from damaged hepatocyte or bile ducts. Specifically, we will focus on the bile ducts if they are obstructed. That means that bile cannot flow out, so conjugated, the liver has already conjugated bilirubin, and it cannot flow, so the conjugated will increase. This could be caused by gallstones, head of pancreas carcinoma, or any obstruction. The amount of bilirubin in the blood is normal, it is not increased. And the liver is conjugating it, it's working fine. However, there is an obstruction that leads to conjugated bilirubin being blocked, and it even goes back to the blood. The absence of bilirubin conjugated in the bile means that it is not going through the intestines. There is no urobilinogen, and this can result in pale stool and a dark colored urine, because the conjugated will go back to the blood and it will be excreted in the kidneys because it is water soluble. It will give dark color of urine. We can further classify post-hepatic jaundice based on the anatomical site of the obstruction, either in the lumen, wall, or outside the wall. Inside the duct or the lumen, it could be caused by choledocholythiasis, either secondary or primary. Primary means it originates in the common bile duct, or secondary when it migrates from the gallstone to the common bile duct. It can also be blocked by a foreign body, such as broken T-tube, which can be inserted in the common bile duct to drain it. Also, it can be blocked by parasites or cholangitis by pus. In the duct wall, it can be caused by biliary stricture, such as congenital atresia, which means there is absence or abnormal narrowing of the duct. It can also be caused by traumatic strictures post-surgery or injury. It can be caused by sclerosing cholangitis, which is autoimmune-related disease, tumor of bile ducts, such as cholangiocarcinoma, or choledochal cyst. This is what it means. So this could cause an obstruction, and it could also cause jaundice. And lastly, we have outside compression. It could be the common bile duct could be obstructed and compressed by carcinoma of the head of the pancreas, or carcinoma of the ampulla of Vater itself, or pancreatitis, or lymph node metastasis. We can also classify obstructive jaundice based on its cause. So for the congenital, there could be the choledochal cyst that we talked about, or the biliary atresia. Also, inflammatory diseases such as ascending cholangitis, which is an obstruction of the biliary tree with pus and infection. Or sclerosing cholangitis, as we talked about, and there could be obstructive causes or mechanical causes, such as common bile duct stones or biliary strictures or parasitic infections, as we said. Also, neoplastic causes such as carcinoma, head of the pancreas, periambular carcinoma, or cholangiocarcinoma, or Klatskin tumor, which can be a tumor of the junction of hepatic ducts. And lastly, extrinsic compression of the common bile duct, either by lymph node or tumor, or even Meriz's syndrome, when we said there is a stone that is compressing the common bile duct. After saying all of these causes, what is the most common cause for extrahepatic cholestasis or obstruction of bile flow? It is gallstones. And now we can move on to the signs and symptoms of jaundice based on its cause, the most common causes. For gallstones, the symptoms are fatty dyspepsia. They are unable to digest fat. The bile is not flowing, and the fat cannot be digested. They also have intermittent and severe pain, as we talked about, that is increased with fatty meals. Also, the jaundice will have a sudden onset and fade slowly in days, like this diagram. For infectious hepatitis, there will be signs of infection, such as loss of appetite, malaise, nausea, and the pain will be dull. As for jaundice, it will have gradual onset and disappearance. Also, we have carcinoma of head of the pancreas. This will have the classic signs of cancer. For carcinoma of head of pancreas, there will be loss of appetite and loss of weight that are seen in almost all cancers. Itching skin. The jaundice will be painless. There is no pain. However, there could be back pain, and the study will be increased as the tumor size increase. The jaundice will also increase. Last type is hemolytic anemia, which will have general anemia symptoms such as malaise, breathlessness, loss of weight, and obviously there is no pain. The onset is slow and it persists afterwards. Other signs and symptoms include dark urine and pale stool in cases of conjugated hyperbilirubinemia or obstructive jaundice. Other signs of and symptoms of obstructive jaundice are pruritus, fatty dyspepsia, steatorrhea, and bleeding disorders because the coagulation factors are affected. For hemolytic jaundice, there will be signs and symptoms of anemia, dyspnea, palpitation, dizziness, fatigue, and history of hemolytic diseases such as sickle cell disease or G6PD. When diagnosing a patient with jaundice, there is a law for certain symptoms called Courvoisier's law. It states that the presence of a palpable gallbladder that is painless and the patient has jaundice, it is unlikely to be caused by gallstones. In other words, it is cancer until proven otherwise. Usually, it is pancreatic malignancy. For investigations, we will do everything that we can to rule out all the causes for jaundice. First is, of course, lab tests, starting with the CBC. We can look for anemia in hemolytic jaundice. We can look for reticulocyte count, leukopenia in viral hepatitis or aplastic anemia, lymphocyte count, thrombocytopenia in hypersplenism, or peripheral smear for sickle cell disease, spherocyte target cells, all the abnormal shapes of blood cells. Also, we need to do liver function tests, which are very important. Serum bilirubin, whether conjugated or unconjugated, if they are increased. Liver enzymes, ALT, AST, and ALP. ALT is more specific for hepatitis because it is only found in liver cells, and AST is more specific for alcoholics because it can be found in other places too. Also, coagulation profile. We can do serum antigens for hepatitis. Also, albumin, which in chronic processes in the liver, such as cirrhosis or cancer, can be low because it is synthesized in the liver. But it will be normal in acute processes such as viral hepatitis or cholelithiasis. We can also do immunological testing for autoantibodies, for example, for sclerosing cholangitis. Another example is primary biliary cirrhosis, which have an anti-mitochondrial antibody. We can also test for lactate dehydrogenase in hemolytic jaundice and hepatitis, and also lipase and amylase to rule out pancreatitis. These are the normal results for the tests that we can do. And also we can do urine and stool sample tests. In urine samples, we can test for urobilinogen. We can find an increase in hemolytic jaundice because there is accumulation of unconjugated, but also the liver will process the unconjugated, but it cannot keep up. But the conjugated will go through the intestines and we will have urobilinogen that goes to the kidneys and will be excreted in urine. However, it will be absent in obstructive jaundice because the bile is not going in the intestines and there is no urobilinogen. For conjugated bilirubin, we can find it in obstructive jaundice because, as we said, the liver cannot excrete bile and it is blocked. So the conjugated bilirubin will go back to the blood and it will accumulate. And we can also find it in hepatocellular jaundice. For hemoglobinuria, we can find it in intravascular hemolysis, not related to bilirubin. In stool samples, we can look for sterocoblinogen, which can be found in hemolytic jaundice, but it cannot be found in obstructive jaundice. Therefore, it will give pale stool. We can also test for occult blood to look for carcinoma of the GI or esophageal varices. This is a table that summarizes all the lab results. First is serum bilirubin. The type that will increase is the direct or the conjugated, because as we said, the liver can conjugate bilirubin, so it will accumulate. And the indirect will be normal. For urine test, there will be an absence of urobilinogen because the bile and the conjugated bilirubin is not passing through the intestines, and therefore urobilinogen is not synthesized, whereas bilirubin will be present because the conjugated will go back to the blood and will be excreted in urine, so it will be positive, and this will give the darker color of urine. For the stool test, sterocobilinogen will be absent, the same reason why urobilinogen is absent too, and this will cause the pale color of stool. As for liver enzymes, ALP would be increased because it is a marker of cholestatic obstruction, and ALT and AST would be normal because there is nothing wrong with the hepatic parenchyma itself. For coagulation profile, PT or prothrombin time would be increased because there is a decreased absorption of vitamin K, which is caused by the absence of bile, which helps in the absorption of fat. So vitamin K dependent clotting factors will be decreased. As a result of that, prothrombin time will be increased. Moving on to the second form of investigation, which is imaging. As we said in gallstones, the gold standard is ultrasound. We can find the cause of jaundice by ultrasound if there is gallstones. We can visualize the intrahepatic and extrahepatic biliary dilation, but we cannot find the site of or cause of obstruction. The downside of ultrasound is that the distal common bile duct is difficult to be visualized, so MRCP would be better to visualize this area. The next thing we can do is CT for mass in the pancreas or intrahepatic lesions. We can also do MRCP, as we said, to visualize the distal common bile duct or for high resolution of the biliary tree. Another form of imaging is percutaneous transhepatic cholangiography, where ERCP is not possible. Of course, this will be invasive too, and it will go through the liver, and we can take the picture with X-ray. Next, we have ERCP, where we can find the location and nature of an obstructing lesion within the bile duct, and also at the same time with ERCP, we can do a curative management. And the last option we have is tissue biopsy using laparotomy. After doing all the investigations, we of course move on to management. Why do we need to manage jaundice? It is to prevent sepsis from cholangitis, to prevent coagulation disorders, hepatorenal syndrome, and encephalopathy. Cholangitis is what's called ascending cholangitis, is an obstruction of the biliary tree with bile duct infection that has obstruction, pus, and inflammation. The symptoms include annual patient pain, jaundice, dark urine, and pale stool, and also what we call Charcot's triad, which is a triad of fever, right upper quadrant pain, and jaundice. If these symptoms persist and it is untreated, the patient can go into shock, and the patient will have also altered mental status, which we will go for from 3 symptoms to 5 symptoms called Reynolds pentad. Reynolds pentad consists of fever, altered mental status, hypotension, jaundice, and right upper quadrant pain. The difference between the two is shock. For the investigations of ascending cholangitis, it is almost the same as what we said before. Blood test, urea and electrolytes, full blood count, liver function test, amylase, C-reactive protein, coagulation screen, and ultrasound of the abdomen. How we treat ascending cholangitis is first by stabilizing the patient if they need IV fluid, if we need to give them intravenous antibiotics, and then we can do ERCP to relieve the obstruction. For the treatment of obstructive jaundice in the common bile duct, we can do ERCP and sphincterotomy, doing an incision for the sphincter of Oddi and removal of the obstruction. We can also do surgical removal of the gallbladder and the containing stones, and if there is stone in the common bile duct, we can remove that. The surgery can be either open procedure or laparoscopic procedure. The last disease that we are going to talk about is biliary stricture, which is an abnormal narrowing of the bile duct. 90% of them are malignant. The most common type of malignant cancer causing biliary stricture is pancreatic cancer, followed by cancers of the gallbladder or bile duct itself, or liver, or even large intestine. There are also other non-cancerous causes such as injury to bile duct from surgery of cholecystectomy, also pancreatitis, which is the inflammation, or primary sclerosing cholangitis, as we explained, it is an autoimmune related disease. Also gallstones can cause stricture, or radiation therapy, or blunt trauma to the abdomen. For the patient symptoms, the patient can present with jaundice, abdominal pain, fever, and vomiting, very similar to ascending cholangitis symptoms. For the diagnostic tests, they are similar to the ones that we explained before: ultrasound, CT, MRI, biopsy, and cholangiography, either endoscopically or percutaneously. Endoscopically is what is called ERCP, and percutaneously is the one through the liver. For the management of biliary strictures, we can do endoscopic stenting or percutaneous stenting. The endoscopic stenting can also be called ERCP. Again, with the endoscope, we go through the intestines and into the common bile duct, where we can insert the stent with a catheter and a wire, and this will widen the lumen of the common bile duct. This procedure has a success rate of 90 to 95%. However, there are some complications such as pancreatitis, bleeding, perforation, infection, or cardiopulmonary depression from conscious sedation. This is an endoscopy, so we will not use anesthesia. We will use conscious sedation that will have a complication of cardiopulmonary depression. For the second method of stenting, which is percutaneous stenting, we can go through the liver in between the fourth and fifth rib of the patient's right side, again through the liver, and we go into the intrahepatic duct under image guidance using X-ray, and then we will add the stent. The indication for biliary stenting, why we will do this, is for ampullary stenosis, or if there is bile duct injury, or if there is benign or malignant biliary obstruction, or even to prevent the obstruction where a stone extraction is not possible. Maybe the stone is small and it might obstruct the common bile duct, so we can do the stenting to prevent it. Or we can use it as a management of selected patients for pancreatic duct stricture and stones and sphincter of Oddi dysfunction. The last thing that we need to talk about is special surgical management options. The first is CBD exploration, or common bile duct exploration. This is when we open and clear the common bile duct. The things that we will do in this procedure is removal of the gallbladder and removal of the stones in the gallbladder, and also insertion of a T-tube drainage in the common bile duct, and we can widen the papilla by transduodenal sphincteroplasty. The sphincter here, we can widen that too. This procedure can be used to reduce the risk of ascending cholangitis on pancreatitis, and we can also use it if ERCP fails or unavailable. The next procedure we can do is raw drainage procedure, where the common bile duct is draining into the jejunum instead of the duodenum. This can be done for congenital extrahepatic biliary atresia. We can also do it for traumatic strictures, for acute pancreatitis, for chronic pancreatitis, or cancer. This also minimizes reflux from the duodenum into the stomach, and we can bypass the obstructed segment to make the flow better. Last procedure we need to talk about is Whipple's resection. This is a very invasive procedure. We remove the head of the pancreas, we remove the distal side of the stomach, we remove the gallbladder and the lower half of the common bile duct, as well as the duodenum and the proximal jejunum and regional lymphatics. All the areas that surround the pancreas we will remove. This is a commonly done procedure for head of the pancreas carcinoma, and we reconnect everything to the jejunum. So the stomach is not draining into the duodenum, the pancreas is not draining in the duodenum, and even the bile duct. We replace the duodenum with the jejunum. And the procedures are three, called pancreaticojejunostomy, choledocojejunostomy, and gastrojejunostomy. The first one, the pancreaticojejunostomy, is the connection of the pancreas to the jejunum. And the second one is choledocojejunostomy, is where the common bile duct is connected to the jejunum. And the last one is the gastrojejunostomy, where the stomach is connected to the jejunum. So as I said, is replacing the duodenum with the jejunum.